We'd like to welcome everyone on the line. We're still expecting some folks, but this certainly is an open hour for office hours. My name is Rick Shepler from the Center for Innovative Practices at the Beacon Center for Violence Prevention at Case Western Reserve University. Joining me today are Patrick Canary, also from the Center for Innovative Practices, and currently Chris Gleason from Rosecrans in McHenry County, Illinois. And we're here to answer any questions or interact with you and discuss with you any questions that you may have around implementing best and promising practices for youth with co-occurring disorders. We can either talk via the phone or you can type in your messages in the chat section, and we'll be happy to begin a dialogue with you. Thanks for coming. We'll give you a few minutes to type some questions in. Hey, Chris, are you still there?
Yes.
Hey, great. While we wait for questions to come in, what I thought might be helpful is for maybe just us to have a kind of a discussion online while we wait for questions about some of the kind of go into a little bit more detail about some of the implementation challenges, but also the opportunities that you've had in your county in Illinois. And in general, what other kind of co-occurring services do you see going on in your state, and how difficult is it to kind of, begin these services, sustain the services, et cetera?
Okay. There's like 20 questions there.
I was going to say that was like 12 questions, I think.
I think the opportunities and implementation is that anytime you start a new practice, I think there's a lot of excitement around that, and to make sure that you build on that excitement with consistent training and follow-up. So one of the things that we were very fortunate through the grant was to have, Rick, you came out, I think, 2-3 times a year in order just to keep the community active and interested in the program, but also to hold the program fidelity. So whatever evidence-based or promising practice that you would choose to do in your community, I think it's important to have those people that can initiate the training and keep that ongoing piece there. I think that's really important because I think that keeps people on target. So it's different than going to a workshop. You learn something and then you go back and try to implement it without that support network. I think that's a really difficult thing to do. So I think that's one of the excitements. It's a challenge, but it's also an opportunity. And so if people are thinking of where to spend their grant dollars, that's probably one of the key places to spend it.
Yeah, that makes sense. So this is Patrick, and I see that we have 2 guests, Joy and Linda. So do either of you have any questions, or both of you have questions or comments to make? And did you attend the previous webinar? I'm thinking you probably did. Anybody want to volunteer? Oh, they're typing. Okay. I don't like the typing thing.
I'm going to remind Patrick we can hear him.
Okay. Oh, great. Linda says it. Okay, so Joy says, we are currently in the process of expansion planning. So I'm just listening in for ideas of how to plan for future implementation. We'll let you know if you have any questions. Great. Okay. Yeah, and Joy, whether any of those questions pop up today or not, I would offer that both Rick and I are certainly available post today's office hours, for any discussion, that you might want to have around implementation in general. We're happy to do that. I think our contact information is somewhere on the PowerPoint or in the TA network Tuesday telegram that goes out. So we're happy to, follow up with you offline if that works better.
And a quick question to Joy. Is your community thinking about implementing co-occurring programs for co-occurring youth, or different? Is it just still under discussion what you're going to be doing in your expansion planning?
And Adam, our tech expert, just posted a note that if you want to call in and talk with us, if that works better for you than the chat box, then he just posted the call-in number and the PIN number. So feel free to do that if that works for you. Wow. So it is really at the front end. Okay. So it sounds like, based on Rick's question, that the potential is there to include kids with co-occurring disorders as part of your discussion about what where the focus will be, or multiple foci. Okay. Well, and as we, just to make a plug for kids with co-occurring disorders, based on, the webinar and the data that, we certainly have experience, and I think Chris could verify this in his experience, kind of that operating assumption that the data is supporting now, that if we're looking at kind of high-end, high-risk kids, and particularly those, it appears, if they're involved in the justice system, we're almost pretty safe, if you will, to make some assumptions about their co-occurring conditions. So I'm glad to hear that's under discussion. That's okay. That's okay.
Yeah, it's funny that Joy has another webinar going on at the same time, so she's got a phone in each ear. Yeah.
So Joy is truly multitasking, participating in a webinar, listening to a webinar, and typing in on a webinar. I'm very impressed. I'm very impressed.
Chris, one of the questions I have, just, it's always, funding is always an interesting issue. In Illinois, I know substance abuse funding for substance abuse programs has gone up and down a little bit over time. Where is it at currently, and how do you, is there kind of a formulaic that you use to help fund your programs right now?
Yeah, the federal block grants do go up and down. We just actually got a 3% rate increase.
Oh, great. And
on the rates, which is, soon we'll bring it up to the Medicaid rate.
Yeah.
Also, too, related to that is that, we probably use more mental health funding for our co-current programs than we do our substance abuse.
Mm-hmm, mm-hmm.
And we can use either one. There's really not any discrimination on that. And Illinois is currently looking to see how they can combine some of those efforts and resources. But our probably best funders are local funding dollar. Are related to, it's consistent, we know it's going to be there, it's based on tax revenue, so that goes up and down, but the community is really committed to co-occurring services, so they make sure that they fund it appropriately. And I think you have to have multiple funders. You cannot survive on one funding stream and run integrated service in any capacity that would keep it sustainable.
That's very helpful.
And I think it's really with the co-occurring question is that we're actually just meeting with a couple of probation officers this morning, and they brought up the whole reason why they like co-occurring services is because they have a juvenile who's at one agency for mental health, at another agency for psychiatry, and then referring to us for substance abuse. And as we furthered the conversation, they were like, well, it just makes sense to have them come here and do all those services in one place. And so still, even after implementing co-occurring services in our community, I know what it was for me is that ongoing education is so vitally important. When you get new people, new probation officers, new whatever coming into the community, to really kind of make sure they understand that the whole breadth of what co-occurring really is, and how to really do that. From our agency standpoint, we just initiated it all through our system, so that people have one door to access instead of multiple.
Yeah, and it seemed to work really well. It was really a sharp, a well thought out implementation plan when you guys did it.
Yeah.
And I'm really glad you brought that back up, which is, there is an ongoing need, not only to educate, obviously you're going to train your own staff, but there's this whole, educating the public and your partners on an ongoing basis about what this thing is that you do, because there is turnover in those agencies as well, in systems.
Right.
And if you have a built-in structure where you're meeting regularly, it's a natural format for those discussions and education to happen.
Right.
So that was nice. That's nice. Give everybody just a quick snippet. So, how many do you guys meet weekly with probation and your planning team?
Yes, we meet once a week with them.
Okay.
We go through referrals.
Go ahead.
Well, the big part is going through referrals, and then also making sure that the partners are invested in the process and that they feel like they're there. We also bring our discharges there as well. So they see a lot at the beginning, but they want to see what happened over the period of time the juvenile was in, or adolescent was in services. So it gives them an opportunity to see the beginning and the end process. And we utilize our partners a lot for other things related to, if we're having a hard time getting medical care, we have some medical people available, problems in probation or schools or whatever. They really become resource value added partners, where then we can consult with them and say, hey, this is what's going on with this juvenile youth, and how do we, best surround them with the community resources that make sense. And they usually try to take the lead and run with that and work with the therapist to make sure that everything's in place.
It's like a mini, it's in a sense that you're kind of triaging it, but you're also, it's kind of like it's wraparound without the wraparound in a sense. I mean, you're already planning for this youth in a professional setting, obviously without the youth and family there, but you're beginning a process of in a sense of system of care thinking around what do we all need to do to take care of this youth at this time.
Correct. And we have had youth come to the panel to present their own case to be in the program.
That's great.
We've had parents come to do that as well. And so, that shows that investment. So you're correct. We do. It does feel a little like wraparound without all the other stuff attached to it. So.
Yeah, it's got to think. The process in terms of supporting and thinking about what is all needed for this youth to be successful is there at that kind of a meeting. It's kind of neat that you do it weekly. I mean, that's kind of rare. I don't hear that much. But it sounds like that's one of the structure and processes that you created that really has helped sustain your practice, your service over these years.
Yeah. Well, and that really came from the community, too. They felt like if we only met once a month or on a quarterly basis, then it becomes a less important process. And now they have it in their Outlook calendar, and they keep it in there, and they come as they can, but generally most everyone's there every week.
I think that's a good point, Chris. What I've experienced in whether it's a clinical type meeting, this is Patrick speaking, by the way, whether it's a clinical type meeting or whether it's an organizational or systems meeting, sometimes when things are left to call us when you need us or call us when there's an issue or call us when there's a referral, it's real easy for that time to kind of tick by as opposed to having a standing time, even if that time winds up, maybe occasionally being canceled because there isn't a strong agenda item. But I think having that schedule I don't want to say forces, but really promotes having a very deliberate discussion because you've set aside the time for it. So I think that's really smart. I would totally agree with that.
Well, and I think another key is time of day as well. And
Yeah.
so we meet at 8 a.m.
Whoa.
And so that allows people to go into their day afterwards. So people are they're starting their day early in order to be a part of the panel process. And we found that if you do it at the end of the day, people are less likely to show up.
Can you come in your jammies?
You could if you needed to. And we
Whatever
provide
it takes,
coffee. Right.
No, that's
coffee is always the key.
Yes, that is the key element. So I noticed that we've had Dr. Christopher Balances joined us. Christopher is managing the clinical track for the TA network. So welcome, Christopher. And we also have another caller who joined us in addition to Joy and Linda. So caller who is 617 area code. If you have any questions either for the chat box or if you're connected by phone, feel free to jump in and join the conversation.
So another
617 is also me.
Oh, gotcha.
Yep. I show up in both boxes for some reason.
Okay, there you go. I thought I scared you away. Okay.
No, I'm still here.
So Mr. Gleason, because we now have two Chris's on the phone. The other question that we've been running into a lot, and we just want to know some of the solutions that you came up with because you've been really good in finding solutions around some of the staffing. Is credentials and what's decisions you made around hiring, and then once they were hired, how you trained. So sometimes they would come in as mental health mainly trained folks versus substance abuse mainly trained folks or licensed. So if you could just talk a little bit about finding and training the different kind of staff that you did hire.
Yeah, it was really interesting. At the beginning process, we took 2 mental health therapists and 2 substance abuse therapists, and we, initiated that training process. I think really gave us the foundation and allowed us to see the strengths and the weaknesses of the therapists from both sides, which actually helped us develop the further training process. So one of the things that we began to offer at one of the agencies is that we offered chemical dependency classes for a year as a training opportunity once a week, and really pushed the education of substance abuse within the organization, but then also allowed the mental health counselors to further the training they received in graduate school, because everyone generally gets at least one class in substance abuse. And so it allowed us to kind of take those concepts they learned that in their master's program and really kind of start to apply it to their real work. And then what we continued to do is we switched our language within the agency from mental health and substance abuse to co-occurring. And so when we're talking about an adolescent, we were talking about their symptomology, not their diagnosis. And that really began to help pave the way to talk about what symptoms are we working on, not what diagnosis are we working on. Because
I think that's,
go ahead. I'm sorry.
No, go ahead. Finish your thought. I'm sorry.
Because I think when you just treat per the diagnosis, then you are then not really kind of engaging in co-occurring services. You're engaging in parallel services that you're doing one thing to get to the other. When you work with symptoms, I think that's when you truly integrate the whole process.
I think that is such a great point. We talk a lot about kind of the dual diagnosis, if you will, and sometimes maybe overly focused on the diagnostic part. I mean, I know that's obviously critical to get the right assessment and the right diagnosis. But once you're engaged in the work, you're right, really focusing on those functional outcomes and the behaviors and the strategies, I think, certainly outweigh, like you said, that kind of using the diagnostic part as the frame as opposed to what do we need to kind of move forward. The question I had, Chris, being a provider, is, we're finishing up our 5th brief that'll be out shortly after this, and it's really around implementation issues. And one of the areas we tackle a little bit is the notion of how prepared are practitioners, coming off of their university experience, how well prepared, shall I say, are they on 2 levels. So my question to you is this: what are you finding in candidates, particularly those coming fresh from a university experience, either in their knowledge of co-occurring disorders, contemporary knowledge, and their knowledge around evidence-based practice and what that means in terms of their practice approach, or how their agency might frame the practice world? What's your experience in your recruitment?
My experience, a lot of it is co-occurring is still not probably a mainstream conversation that people are having in graduate school. And so I think people have the language coming out of graduate school, but I don't necessarily think they have the knowledge base in that piece. So predominantly what we get walking through is people with heavy mental health and practice, and unless they've had an internship at a substance abuse facility or something like that, that's really probably one of their weak areas still remains, that substance abuse piece. And I think it's really hard to kind of filter that process out with them to get them to see, because, and I get it, coming right out of graduate school and excited to practice, they have all kinds of ideas of what the world of counseling or therapy or social work is going to be. But really our training plans in the first 30, 60 days is really heavily focused on more of the real world. This is what it means. And I think in terms of evidence-based practice or knowledge of it, I think it's touched upon, but I don't think they have an understanding of what it really means to follow the fidelity of an evidence-based practice.
Okay.
So fidelity teaching, I'm not 100% sure that that's out there. I've had an opportunity to teach at 2 universities and, really kind of push that. But even in the department, people are kind of like, well, we need to, we're not at that place yet. So it's an interesting conversation.
And I wish I could say it was any better with child psychiatry, but I think similarly, even for someone who is embedded in a training program in child psychiatry, I don't think we do nearly a good enough job in preparing child psychiatrists to work with youth with substance abuse disorders alone or even in co-occurring situations. And I think there are select few who go on to get additional training in that regard, but I don't think most child psychiatrists just coming through the standard fellowship are feeling prepared to work with that population.
Yeah.
So the whole pre-service end, regardless, seems to be, needing an infusion of not only curriculum, but there needs to be a will to move forward on that. Because if you're a university setting, there's a whole set of, I don't want to say politics, but I'll say the word politics. There's a whole set of protocols you have to go through to get a new course or a new set of curriculum online. And it's actually quite extensive. And then you need enough students that want to sign up for that thing.
You know how you get it to happen? You make it part of the licensing requirements.
There you go.
Or you start testing on it in board examinations or licensing exams.
Yeah, that makes a lot of sense. I'm, and I'll speak to both Chris's, if you will. Are you guys aware of any states that have dual licensure or unified licensure for substance abuse and mental health?
I'm not.
No, not that I've seen either.
Yeah. So we still have kind of siloed licensing systems, I think. in
Yep.
many states. There might be one or two that don't. I know a couple, whether it was CSAT or SAMHSA at the time, were trying to, have folks do planning grants around some of that, but I don't know how far it got. I know Louisiana was looking at that at one point, and some other folks.
I mean, the
Actually,
federal government
the,
a role.
oh, sorry, go ahead.
The federal government can play a role by leaning on some of the academic accrediting bodies to address this if it's a big enough concern for the federal government. So that's the way SAMHSA can leverage action, and there's some precedent for that in medicine when there's been concern that medicine hasn't been responding to some of the federal initiatives, federal healthcare initiatives. And I think if we put this in a public health perspective, that'll be language and the levers of how to affect the kind of change that you guys are talking about, I think will become more apparent.
Mm-hmm. Mm-hmm.
That certainly makes a lot of sense to me. For the longest time, I mean, I don't know that it's, there, at one level you might say, well, not all the clinicians want to do this kind of work, but at another level they may want to do it but don't know, we don't have the right structures in place.
Well, and I think they're already working with this population without knowing they're working with this population because they're not asking the questions because they don't feel prepared to respond to what they learn.
Right. Right.
No, absolutely.
And we have a huge problem with diversion of stimulants. We've got a big problem with how opiates are also being diverted and how we're addicting people and then they go on to develop heroin addictions. They're concerned enough in Massachusetts that they've set up a registry for physicians where you can go online and see if your patient is getting prescriptions from another physician. Insurance companies send me reports about that as well. So, the other lever to pull is to make this a quality improvement indicator through the insurance companies.
Mm-hmm.
Yeah. And accrediting bodies, whether it's JCO or CARF or COA.
And licensing bodies. At this point we need to take certain CME courses that they've set up online in order for our relicensing as physicians.
So, Christopher, I guess this is Patrick. Both Chris and Christopher, I guess I'd be interested in knowing your thoughts about, given, what always strikes me, and, I'm not a clinician and not a researcher, so I come at this from a program implementation, kind of policy, development area. So it always kind of amazes me when we do, webinars or we do presentations or attend presentations and we see the data around the prevalence of co-occurring disorders in adolescents, and it always strikes me how wide the gap is between the knowledge of that prevalence and the capacity to address it. And I know that's a big question, but I would be interested in both of your thoughts on what's your hypotheses or what's your speculations about why there's such a distance there between a known, quote, disorder with terrible adverse consequences if not addressed, and yet the gap for capacity to address it is so significant. I guess that's just my question to you both.
Well, I have a couple of thoughts. I would say that there's a huge problem with the uptake of evidence-based practices writ large, and there's a whole implementation science that I'm sure you're aware of, trying to figure out how to get at that issue. And in mental health, I think there is an aversion amongst a number of dynamically trained clinicians against anything that is manualized. And that tension between manualization in order to develop fidelity and standardization of approach and the notion of we're all individuals and wanting to individualize our approaches. So, that's that's been a dynamic in the field, I think, for decades that we haven't fully cracked, although I think Bruce Torpeda and his common elements approach is an interesting way to, round the square or square the round and get people interested in this. And interesting enough, when he does kind of satisfaction surveys of the trainees who are typically mental health folk, they really like that approach because it both gives them the skills while also allowing them to individualize the application of it. But whether it remains an evidence-based practice when he's broken up the modularization of it and the manualization of it, and therefore has he lost the fidelity, I think, is where some of the evidence-based practitioners are pushing back. But I think that might be a really interesting compromise to see the trajectory of that. And I don't know if he's broadened that into substance abuse treatment and treatment for co-occurring disorders. Do you guys know if MAP has a co-occurring disorder or substance abuse treatment component to it?
I don't. That's a really good question, Christopher, and I'm going to reach out to Bruce and ask that question.
I mean, certainly.
Quite honestly, I'd be surprised if he doesn't, but that's a good question. I don't know.
I would be surprised as well, because,
yeah.
I mean, the whole motivation for it was to get at the conditions that, there weren't evidence-based practices for, but certainly to take advantage of the evidence-based practices that did exist,
right.
And teach the skills to the clinician. Right. The other piece that I think is exciting about MAP is that it's really about a clinician support tool for both the assessment and then the treatment of patients. And I think part of, what reinforces mental health folks from not entering into the treatment despite knowledge, I think, of the problem is a concern that they don't have the training and that they don't have the skills to be able to know what to do.
Yeah.
And even something as simple as motivational interviewing, I don't think is being properly trained, at least in child psychiatry fellowships.
Okay. Yeah. Which is one of the services we're trying to add to our portfolio here. We have a sister center of excellence here at CASE who work primarily with adult folks with severe mental illness and co-occurring disorders and are real true experts in MI. And so we have a staff member over here at our center kind of being mentored and tutored in order to really make that effective for adolescents particularly. And then he'll go through his, I think it's called MINT certification, or I'm not sure of all the acronyms for that, but that is, and it's also an intervention, MI, that I see that seems to have a lot of resonance with providers.
Yeah.
So something we definitely want to add.
I think, Christopher, one of the things that you're raising is also, this whole hesitancy on behalf, for example, of mental health and or substance abuse providers, whatever they've been trained in, to do the other thing. They feel like they're not able, capable, trained, and it's getting at the hesitancy, and then how do you support that? And so I don't know if Chris Gleason's still there, and if he is, I'll ask him to speak to this as a heads up. One of the things that I thought you guys did that was so different, and I had no idea if it was going to work, but lo and behold, not only worked, it was like stellar, right? But I want you to speak to, the hesitancy of learning, but you guys had a unique supervisory setup that I thought helped folks get all the clinical supports they need, so that they could learn both as they needed to. So why don't you talk a little bit about that for a minute?
Yeah, what we did is split the supervision of the ICT program into part of one person who's primarily mental health and one person primarily substance abuse. So myself and another colleague came together and we sat around the table and looked at each other and said, I have no idea how this is going to work, but let's see what we can do. And I think what it did, the added value in that was our ability to learn from one another and then transform how we did supervise people and take those, each individual ideas together. And by the end of the, or not by the end, but through the process, we just began to call ourselves co-occurring supervisors rather than mental health or substance abuse supervisors. And it really is, my thought process on this too is really it's a cultural shift within agencies and providers to really begin to see themselves as not one as or the other. And that takes a lot of work, but I think where it really begins is really those people are down there providing those services to make sure. Because I came in as a staunch substance abuse therapist, been one for a long time. I remember back to the days I actually started as a drug counselor, not an alcohol and drug counselor. And, even at that point, the alcohol counselors sat on one side of the room, the drug counselors were on the other. So even within substance abuse, there was a division of who had the, more hardcore clients to work with. And so I kind of came into that process with that mindset of I'll just focus on the substance abuse and let them handle the mental health. And really by the end, I go back to what we really started supervising on was symptom and symptom intervention rather than diagnosis and diagnosis intervention. And so really continues to be my mantra today as a director and supervisor of clinicians is, what are the symptoms that we're working with, not the diagnosis. And as for larger agencies, that just takes a while for it to permeate through there. And really, it's how you use the language around that. I don't know if I answered your question.
No, you did it perfectly and eloquently. So, there's a culture shift that needs to happen. There is a time and a process for which that happens in. But there's also, for lack of better words, a building of confidence with providers, supervisors, and agencies, right? Right. Within the agency. So, where maybe at the beginning, each provider was wondering, can I do this other thing? And at the end, they probably self-identified as co-occurring.
Right.
As a co-occurring therapist.
And it's intentional supervision too. And I use that all the time is that we need to be intentional about what we're really kind of working through. And to really, if you don't have the strength, to pull in that strength to have that person come in and work with that. And really, it's not hand-holding, but really the first 6 months of somebody walking in out of graduate school, they should really supervision should be so intense that they always feel like they have a walking encyclopedia next to them, a resource that they can ask those questions. Because left to our own devices, out of graduate school, it's you're excited to be out there and you're just, picking and choosing. So I think that helps hold it and the fidelity of it, and if they have access to that information.
I'm envisioning you as a walking encyclopedia right now.
Thank you. I should have said a walking smartphone. I don't think anyone knows.
Or something like that. I mean, I see a very square face now with pages.
But I think we want to make sure that we don't, make it seem like you need to be a walking encyclopedia to know how to help these folks. And,
correct.
Demystifying it. The way that I get inroads into helping people to get on board with using evidence-based practice is to suggest to them that they're using components of evidence-based practice all the time. So that part of what, evidence-based practice is almost, language change and a translational function, and connecting the dots between their usual care approaches and some of the elements embedded in some of the evidence-based practices. I mean, motivational interviewing, is not rocket science. It's not even something that I think is particularly unknown to therapists. They just haven't necessarily used that term or thought of it in that way. And I think that's why it's something that a lot of clinicians are drawn to, because I think it's something that makes sense to them and fits in their kind of therapeutic paradigm.
Right. Well,
I'd agree. I would agree with that as well.
Well, I think a lot of it is demystifying it. So there's a part of this is just building the confidence that you can do it. There's another part that is that you're probably already doing pieces and parts of it already, let's label it and relabel it. And you probably already have many of the skill sets necessary to do the work.
Exactly.
So let's help you frame it up.
And these are your patients. So, and they need this help. And, so long as we have people that bill themselves as substance abuse counselors, I think the inclination amongst the mental health type is, oh, good, I don't have to do that because there are people who subspecialize in this and I just need to make a referral.
Right.
Right.
And that's only, over the years caused many actually, bifurcation and problems over time when we refer out and wait for the kids to come back years later after they're cured. That was sarcasm, sorry.
Illinois has done a good job. They have an Illinois Center for Excellence on Co-occurring Disorders.
Okay.
And they do offer a multitude of trainings and consultation and kind of, they'll come out and do the DD-CAT survey and do all those different kinds of things to make sure that, where people are at and how to provide those resources.
And I think it's really important, Chris, thanks for bringing that up, is that many of the states, so regardless of where your system of care is located, we are trending toward this whole idea that let's have located at universities in many of the states these centers of excellence. I'd be looking to what exists in your state that where you can get added, training or consultation or TA on these things. Chris, where's it located at which university?
Actually, it's located out of the Department of Human Services, interestingly.
Oh, okay. Interesting. That is interesting.
Yeah. Yeah, no, they put the resources into that. So.
And Chris, this is Patrick. I want to follow up with you on that offline. I've been working with some colleagues at the University of Maryland there on putting together some tools and resources around the whole notion of centers of excellence. And part of our goal is to continue to try to identify organizations that are kind of fulfilling the functions of a center of excellence. So I'm going to follow up with you about maybe some contact information.
Okay.
Great.
And just one more question, maybe, if we don't have any other comments from folks. One of the questions that, is kind of on the table, it's more of a clinical one, Chris, is, when, we've been talking a lot about community-based programs. When do you make a decision to send kids to a higher level of care when they're, around substance abuse in particular, but just, in co-occurring, but substance abuse in particular, when do you guys make a decision like, okay, this is, a line in the sand, these kids need a more restrictive, safer environment? What are your thought processes around that?
Well,
like
I think, right, we look at the risk factors mainly, and what are we able to maintain them in the community at home based on those substance abuse risk factors. Some that are immediate, let's look at residential, is any opiate or benzo use because of just the medical related complications on the benzo use, but the opiate related to the pathway and that it could take. And a lot of times when the kids are in that deep, we know there's a lot more going on. And we just, I usually call it, and it's probably not a good medical term, and there's no scientific or anything written, but there's a brain break really is what we're looking for these kids, is that they're, to see what else is going on there. So we try every intervention within the community first before we recommend residential. But it's ratcheted up by use, heaviness of use, pattern of use, no attempt at quitting to use. Their use has become at that dangerous level point. All those different factors kind of play into that.
Play in.
And if they're not connecting either, if they're missing appointments and they're not going to school and we're not able to locate them in the community, and trust me, man, we go everywhere to try to find them first. Not opposed to doing a session at McDonald's. but that's really is looking at what that risk factor presents for themselves.
Yeah. Thank you.
So it's different for every kid. I wish I had a formula that would say, if they did this, I came out of the training in substance abuse where if you had 3 dirty screens, you went to the next level of care.
Mm-hmm.
Well, kids who were smoking pot always went to the next level of care because they always had 3 dirty screens in a row.
Right.
How it processes out of the body. And so we really try not to base it just on those sole factors of drug screens. We kind of take a look at how are they interacting in their 5 areas of focus: home, community, school, peer group.
Yeah, that's great. And then benzos and opiates in particular are 2 areas of concern in terms of the actual drug categories.
Yeah, those are my big ticket items. We really need to make sure we have every intervention in place.
And so, I know, do you see trends in terms of residential availability? I know, like in Ohio, we've seen, I don't want to say a downturn or a downtick, but there's less residential available over time in terms of substance abuse. Is it the same in Illinois?
No, I think we've probably been consistent. I think what we're finding is insurance companies aren't readily approving residential stay.
Okay.
So they would like to keep it in the lower levels of care.
If at all possible.
If at all possible, which makes sense. They're trying to work with the benefits that the families have. But our residential facility in Rockford is pretty consistent.
Not great. And I only bring that up is that if you're implementing, a home and community-based program or looking to do that, it doesn't negate the need to have a complete continuum of care in your county or locale where you're doing this. There still is the need for more intensive things depending on what's going on for the kid. And we usually base those decisions on risk factors and sometimes the type of drug and the risk behaviors that go along with it.
Right. And we're fortunate at Rosecrans to have that availability at all those levels.
Within your agency itself.
Within the agency, yeah.
Yeah, that's nice. Okay. Well, we're getting on till about 3 o'clock, and Chris and I can talk the whole day, but we want to make sure that we've answered all of your questions. And Joy and Linda, if we've brought up a bunch of different issues. If you had any follow-up questions to us before we end the call today, we'd certainly entertain any last-minute questions. Otherwise, Chris will be singing a holiday medley to you for the next 6 minutes. And did you bring your guitar?
You do not want that. That should be motivation enough.
And both the callers just left. Just kidding.
Yeah.
So Joy does not have any more questions. And all righty. Is there any last minute comments you want to make, Chris?
No, I just appreciate you having me as part of the process. Thank you.
Oh, our pleasure. My God, you made it much richer.
Yeah, thank you so much.
As always. All righty. Well, then we'll go ahead and finish this office hour. And again, as always, if you have any follow-up questions or TA requests, our contact information, I think, is on the original PowerPoints, and we'd be happy to talk with you. Thank you very much, and have a happy holidays.
Yes, same here. Happy holidays, everybody. Thank you.
Bye, guys.